let's talk about treatment, because all of this has been funneling toward this final common pathway. We understand that there are various presentations of this disease, there are various courses of this disease, and the object is to preserve function and to preserve gray matter and white matter. I think that that's sort of where we've gotten. So how do we do that? Now we're going to talk about treatment. Are there National Multiple Sclerosis Society recommendations generically for treatment, and how do we start with that?
Well, we don't just have National MS Society criteria, we also have from the Academy of Neurology, we have from other players in the MS field, and principally what it says is if a patient is diagnosed with a relapsing form of multiple sclerosis, this patient should be offered treatment. Second point is obviously with newer treatments available, we also have patients with primary progressive multiple sclerosis that have now access to treatment, or at least one treatment. We will talk about that later on. Over recent months, we have had approval of agents with a specific call-out for active secondary progressive disease. So as Pat Coyle and I have mentioned, we still look at this as probably relapsing forms of multiple sclerosis and apply the treatments that are available.
Are there specific guidelines for SPMS, or are they more general?
So I would say they're more general. The American Academy of Neurology AAN practice guidelines were published in 2018, and they had a series of recommendations on initiating treatment, on switching treatment, or even considering withdrawing it. So they speak a little bit about SPMS, and they really refer to the fact that if there is a relapsing component, that patient is entitled to be on treatment.
What is your perspective here? How do you capture progression? I mean, clearly, they're talking about progression. So you're sitting there saying, how do I measure that, right?
Well, and also that's where the coding becomes important, right?
Or lack thereof.
Or lack thereof, exactly, with one code. So usually it's the pattern. And it also depends, you have to remember what payers have is claims. What did we pay for? And so what did we pay for is also dependent on the history with that patient, with that payer. And Dr. Leiss mentioned before Medicaid. The Medicaid patient may be in and out of the system. And so many times we lack the historical data of, has that patient been in the ER, been hospitalized, been on corticosteroids, been on IVIG? What is that pattern and over what time? The average commercial member is with a payer on average 12 to 18 months. And when they go to another payer, that other payer loses that full history.
Can you back this up? They're on a single payer for 12 to 18
They're
months.
on, we don't have a single payer
no,
system.
I mean, but I didn't mean to say single payer. A given commercial payer.
A given commercial payer.
Where do they go? What happens to them?
They may lose their job, right?
Okay.
They may go to part-time. They may go on Medicaid. And so the tragedy is often sort of the lack of continuity and understanding that patient journey. And so when a physician, back to the physician then calling to say this patient has highly active disease, which we may not even have the history that's long enough to be able to say MRIs, what have they been on, what treatments they've been on. And so the reliance also on the provider to help us understand what has been tried, what has the patient failed, is it lack of efficacy or tolerability, is it highly active disease or lack of compliance. And so this becomes so nuanced in the context of that individual and their journey.
You know, we could call this an episodic disease. We can call it an episodic payer disease too.
Well, it's a chronic
that's
disease.
That's really interesting.
Yeah.
Because if you don't carry forward
exactly
the patient's history from payer to payer, how is the payer supposed to know what's going on?
Well, but let's be very clear. So MS is not an episodic disease. It has episodic clinical new manifestations. It is an
How about chronic relapsing payer disease?
It's a disease obviously that is ongoing in the individual. Where this becomes more important is also when we look at the mode of actions of different treatments that we have. every year the modes of action or the different agents may be differently positioned in an armamentarium that is available to the patient. That's the formulary. It is very important that a patient that has failed a given mode of action within a formulary is not re-exposed to that mode of action, because it's unlikely going to help later on. And so that's where this also becomes important, to know the treatment history of an individual.
You know, it's shocking to me. I never knew this. That number of the number of months that a given patient is with a particular payer, that's shockingly small. It really is. And the lack of continuity of information about a patient from payer to payer makes a big difference, I would assume. So given that, and we're going to get deep in the woods in a few moments of pharmacology, but the current treatment options for RRMS, not looking forward at some of the newer therapies, what are the standard options that all doctors prescribed and still prescribe?
So I put them into three groups. We have the injectables that go back to the 1990s. This would be all the interferon betas, 5 different, and gluteramine acetites, the brand and 2 injections in 2 different forms. 5 orals. The oral era dates back to 2010, 2013, 2 originally added. And then the intravenous monoclonals, there are 3 of them currently that are the high efficacy agents.
But I want to back up, because we're going there, I promise you. But what you would have heard a decade ago, and you still hear, I would suspect, are lifestyle modifications. Does that help?
Oh, we are increasingly learning a wellness lifestyle has positive impacts on the brain and the central nervous system. And if you don't follow a wellness program, you are negatively impacting anatomically on your central nervous system.
That goes back to
this
exercise,
gets back to the reserve.
cholesterol,
Absolutely.
blood pressure,
Absolutely.
blood sugar, all that stuff.
Absolutely.
Okay.
As an adjunct to treatment.
Yeah.
Yes.
We're going to get, I
yes.
promise you, we're
A
going to get
key
to that.
to hit that reserve,
Yes.
that brain
but
reserve.
I want to get
CNS
this
reserve.
kind of platform, the minimal platform
Well,
first.
so let's talk about following a wellness program, recognizing comorbid conditions and getting them treated, recognizing the symptoms of MS and getting them appropriately treated. If you have an acute attack, there's a treatment for that. And then we have the disease-modifying therapies.
Now, historically, muscle relaxants, pain relievers, and
Symptom management. Well,
So I do think we have to differentiate. You bring up a very important point. So when we talk about MS treatment, we are talking about medications that are meant to modify the disease of multiple sclerosis. As individuals incur injury because of multiple sclerosis, they develop secondary clinical manifestations due to this injury. For example, stiffness. For example, walking difficulty. The problems can also be on another side. Fatigue, a very important symptom in MS. Mood disorders, very important symptoms in multiple sclerosis. These then require treatment with other agents targeting these symptoms.
those are secondary
for
signs.
quality of life.
For quality of life.
Quality
But
of
they're not-
life. They don't prevent damage
They're
from
not
the disease,
disease
but quality of life.
modifiers.
Exactly.
They are quality
Exactly.
of life
Yes.
interference
Yes.
drugs.